Hello children of a lesser joint, welcome to today's segment. This is part 7 of Can the Lateral Pterygoid Muscle Cause Disc Displacement? You get your real answer today. Disc displacement is caused mostly by fibrosis, not muscle. In this section, what I'm going to cover is fibrosis. Notice that fibrosis is downstream from a root cause. And ultimately, that's where I'm going to work towards, getting back to the root cause. In describing fibrosis, this comes from an inflammatory process. The problem in dentistry is that we selected from an injury model that was related to compressive trauma. If you remember, I talked about the Holy Trinity: clenching, grinding, bruxing as similar terms, and then of course related to a bad bite. But I'd like to show you the MRI of one of my patients and then talk about different aspects of this and actually help you to visualize this by an arthroscopic procedure, which is a powerful tool in being able for you to visualize exactly what's going on in the joint and why we need to change our clinical perspectives in relation to this. This is the MRI of one of my patients. This is the left joint, and you can see that there's breakdown of the cortical bone. The cortical bone would be exampled by this black line around the condyle over here, and the cortical breakdown by the mustard color arrow. Above that are these little like black studs, which are likely to be synovial remnants. And here in the yellow arrow, you can see, as I outline this with my white mouse pointer, the displaced disc. Now, in all over here is fibrotic tissue. And there's inflammation behind over here. And there's the fibrotic tissue. When we look at the arthroscopy, we can see that what you're looking at here now are inflamed blood vessels of the synovial tissue. The synovial tissue is undergoing inflammatory changes that are not only described by vascular damage and inflammation, but also hyperplasia. Hyperplasia meaning the deposition of fibrous tissue within the synovial layer. And you can see in this arthroscopic procedure, as the oral surgeon, Dr. Howard Israel, is beginning to go ahead and clean that out, all of the fibrous tissue that exists there. However, it's not the only thing that's present, because incorporated into this are joint effusions, and you're going to see little pockets appear, which I'm going to point out. You've got one coming up now in the top right over here, where you'll see these gross spaces develop. So you realize that the fibrotic deposition is not heterogeneous throughout the joint, that there are little areas which have voids in them, and that is where the joint effusions are located. And here you can see that pocket that's developed as kind of like a big hole or void as the tissue is being cleaned out. Notice the cotton candy and filamentous appearance of all this fibrotic tissue that causes a tremendous hindrance. And look at the adhesions that are going on in this. So there's limitation of motion and ability to open. Notice those little adhesions in addition to the fibrotic tissue, which have a more coarse type of appearance. just letting this run and having you see the full pathology of what's going on inside the joint. And notice how angry that tissue is. Got that little rotor-rooter action there. That's so cool. Now, this patient actually had a combination of Lyme disease as well as Hashimoto's. And you can see everything is all cleaned off pretty much and still kind of flushing that joint out. You can see the eminence up over here. And he's pulling, Dr. Israel's now pulling back on the disc to mobilize it. This patient did extremely well. It's over 5 years now, and she is grossly asymptomatic on this left joint. However, when we take a look at the MRIs of this patient, I'd like you to see a couple of other things. Now, this is a different image other than the proton density, which would be an equivalent kind of to T1 image. But this is the image called a fat saturation study done with contrast medium. And where it shows up white in over here, where all the inflammatory changes are occurring. Now, if you'll notice that, of course, within the bone marrow, notice how in this picture you can see the cortical outline from this slice. This is all inflamed inside the bone marrow. We call that a bone marrow lesion or bone marrow edema. And up around it, you can see that there's synovial fluid, what we call a joint effusion, or just as you would have fluid in the knee, fluid in the jaw joint. And here is the displaced disc, and you can see, while it's not quite as bright as over here, this is enhanced by the contrast medium. And I will tell you that had I not done this with the contrast medium, that lesion would never have been picked up. I also want you to make specific note of the fact that the condyle is backwards in the fossa. In other words, it's pushed towards the back of the fossa, which I'm going over with now with my mouse arrow. Here is the back of the fossa, and notice how close this is to that back wall. Not only is there disc displacement going on here, but there's also condylar displacement going on here. If I take a look at a different patient who has a few autoimmune diseases going on, among them is vasculitis, on the left side you'll notice that I have circled the condyle. Notice how small it is, but this is a closed position, and look at where the condyle is. It's sitting right over the crest of the eminence. So this is a forward posturing condyle, and I'm going to show you a panoramic of this in a little bit so you can really see how this joint has been evicted from the fossa. And here is the volume of the tissue, which is likely to be mostly fibrotic in nature, with the white arrow pointing to the inside of this volumetric area, and the red area, just so you'll see it clearly, is the condyle. Now, this is a joint, actually bilateral. You're only looking at, I believe, the right joint here. This is a joint with a very high destructive index bilaterally. If we take a look at the bites, I'll show you the bite of the top patient over here. She mostly hits bilaterally on her back premolars and molars. She had come to me with an NTI in place, which she barely wears, hardly ever, because it kills her joint. It really hurts her. So this was used as a diagnostic aid just to provide her with some temporary relief. However, on the bottom patient, we have a gross bite abnormality described by a bilateral anterior open bite and constriction of both the upper and lower arch forms with a tremendous overbite, an overjet. I'm sorry, not an overbite, an overjet, where this is highly retruded lower jaw. So you can see that there are differences in not only disc displacement, but condylar displacement as well. And if we take a look at the same patient with the open bite, you will notice on the panoramic x-ray on the top left the aggressive features of a patient with a vasculitis, where not only the destructive process occurs in the condyle of the temporomandibular joint, but also in the bony element called the coronoid process, where other muscles attach to, like the temporalis. Notice where the fossa is, highlighted in yellow. So this is a joint that is under significant siege bilaterally. In Tasali's articles, he talks about the dynamics of joint pathology. And one of the things that are pointed out here is that not only are we dealing with different inflammatory issues of the tissue behind the joint, the retrodiscal tissue, as it's called, but we're also dealing with different positional deformations of the disc as described over here. And that will create different patterns of pathology and movement of the disc, which could also occur backwards. It doesn't have to be a forward displacement, as well as joint pathologies. And when we take a look at the literature, they do talk about RA in this particular article as well, but I needed to cut to the chase over here. When you're talking about the synovial tissue changes, you're talking about thickening of the tissue with increased vascularity, as you saw in the arthroscopy, with inflammatory cells infiltrating into that area. So here's my immune response. This is also an immune issue. And so we're dealing with thickened synovial tissue called hyperplasia. We're dealing with inflammation of the synovium called synovitis. We're dealing with the deposition of fibrous tissue, which is crowding out normal structures and causing failure at multiple tissue levels, destroying, in part, the blood vessels and crowding out all of the normal structures and their normal positions with superimposed immune responses. This is what we're dealing with most of the time. And there is a large spectrum here in the type of hyperplasia that occurred, being far more remarkable in rheumatoid arthritis than osteoarthritis. But notice how I've highlighted the area in red to talk about the fibrotic tissue deposition, and fibrotic tissue comes from the deposition of fibrin. Now, where does fibrin belong? And where does this come from? Because if you're going to get to the root cause, you've got to be able to describe the inflammatory and pathogenic changes that are occurring and why they are there. So I took a cross-section of some articles. I have hundreds of articles in this category, and I want you to take a look at it, because when you talk about fibrosis, you're talking about the coagulation system. And unfortunately, what's happened in medicine and dentistry is that we've selected from a wear and tear model. That is not the most common cause of inflammation here. Not even close. Because if you talk about tissue injury, not only do you have blunt trauma, not only do you have people who have cuts or wounds forming, but you also have that which come from the injury of autoimmune diseases and infections. And that is the most sustained cause of fibrosis in not only joints, but all of our organ tissues, where it occurs most commonly in the lung, or the kidney, or the liver. It also occurs on the inside of blood vessels. So we have endothelial dysfunction, and in the wall of the blood vessels, this can occur in the vasculitis category. So we have a lot to account for that we haven't really been taught about. And I hope this is of benefit to both the docs and the patients in understanding this. In an article written by Matsumoto, just to show you about the inflammatory cascade, when we look at patients who have internal joint derangements, which means they have disc displacement and the inability to function normally most of the time, at the very least they will have clicking and popping, whether with or without pain, but they could have a limited range of motion and a full banner of all sorts of symptoms. But here are the inflammatory cytokines, which are signaling molecules that are involved in the destruction of joint tissues and in other areas of the body as well. So here is the common grouping: TNF-alpha, interleukin-1, interleukin-6, and then sometimes interleukin-8 as our pro-inflammatory response. However, I'm going to show you something next from a bruxism model. This is an article that is done by Muroi, Japanese article in 2007. Now, this is a one-of-a-kind article, and here's what Muroi did. He took surgical explants from live donors undergoing joint surgery, and they were subjected to cyclical forces. And these cyclical forces of compression were modeled after a sleep bruxism study by Guy Lavigne out of Canada, I believe Montreal, as the premier investigator in dentistry of sleep bruxism. So when they applied these compressive forces to the synovial tissue biopsy, what they found out was those inflammatory cytokines were not part of the detectable assay levels. They weren't being produced. What was being produced are other inflammatory mediators on the left, and notice interleukin-8, which was not part of the quatrain I showed you in the prior article by Matsumoto. Now this is interesting because now if I have inflammatory changes in most joints where synovial fluid is being evaluated by assays, then I have to describe where IL-6, IL-1, and TNF-alpha, tumor necrosis factor alpha, comes from. Interestingly, Caruso's article shows that when you have pure bruxism, the joints are larger. But here I am dealing with joints that are being destroyed in people who think they clench and grind too much, and that's what's causing the failure of their joint. No, they have an inflammatory disorder, and the idea is to get to that inflammatory disorder as the root cause. So why are they there? They are aligned with the innate immune system. They're there predominantly to defend against pathogens. And here arises the big surprise to dentistry. Yes, we have found that there are microbial pathogens in the temporomandibular joint and in every other joint in the body that wants the sanctity of that joint has been breached, whether the source comes from the blood, the source may come from the blood from a surgical procedure, from an infection in an adjacent area, their primary responsibility in describing the presence of these cytokines is to defend against microbial organisms. So in showing you where the fibrotic tissue comes from, notice I can enter into the coagulation cascade where blood clots come from, and this is where fibrin comes from. I'm not going to go into this in detail. However, what I'd like you to notice is the source of this in the top left. Bacteria, virus, fungus, parasites, and the toxins they produce. And that's going to trigger parts of the coagulation cascade in the production of fibrin, which produces fibrous tissue. And it can also be triggered by the organisms causing cytokine release. Here is the cascade that I have in my 2 articles from 2014 in Dentistry Today called TMJ Rediscovered. Part 1 and Part 2 in the November and December issue. Now that's posted on Children of a Lesser Joint discussion group in our group files. So when we take a look at another MRI, what I would like you to see in this, notice how we have all this fibrous tissue. But when we look at different parts of the joint in different images, notice these huge, really big joint diffusions in the anterior part of this right joint and in the posterior part. We also have these little black spots over here which relate to osteonecrosis. So when I take a look at the T1 image, I see the black spots over here and the black spots on the T2. That's osteonecrosis. This patient had antiphospholipid syndrome and probably a lot else. She did have Hashimoto's disease. And we take a look, and this looks like the end of a wrench over here with these erosive lesions. And I'm just confirming in this slide that there is osteonecrosis. Just a little low. And when I take a look at how this thing wraps itself around the right joint, take a look at this. It does not have the same fluid concentration throughout. So here we go. Here's 1, 2. Notice how this is presenting. Front and back now with fluid in the jaw joint. Front and back. Here are my black dots again. The osteonecrosis. There are other focal areas here which I'm not making mention of. But you can see. And when we take a brief look at the synovitis over here, very similar to the other patient. Let me just go a little bit forward over here. Notice how we're going to come across the fibrous tissue. This is a little denser and coarser than the prior patient arthroscopy I showed you. And notice how you come to those pockets where there are joint effusions, and you see some of these adhesions in here being some of the whiter, milkier tissue strands. Now here's what I'd like you to think about. When we take a look at the histology of a normal joint, the Shishmolke's article, notice back here there's a black star. And this black star relates to the vascular tissue behind the joint. You'll see other stars come more forward of this because there's more to this story. Here is the parotid gland. In describing both veins and arteries, notice that the veins are a little bit thinner, narrower, of course, more convoluted. And so this is a site where the fibrosis can actually start within blood vessels, and how blood vessels in the venous part of the system, remember this is the part that returns to the heart, can get more easily clogged and form thrombin clots. The arteries over here are more circular and have greater opportunity for blood flow to come in and are more open. So when we take a look at a cross-section that now has the open stars in the front, this is my vascular complex in the front over here. Now I want you to think now, what happens when we open? Because when we open, the parotid comes up underneath the vascular tissue that's behind the joint. And this opens up like a leaf. Notice there are two parts to this. And this is the first patient I'm showing you. And notice how this is enhanced in here where you see inflammatory changes in this joint. This is the left joint. And parts of the tissue are highlighted by the contrast medium, as they are over here. Notice there's inflammation going on in the front where these vascular complexes are, right over here as I point to open stars. So this is an overlooked area. But what I want you to think about is this. There's the disc. If I put an appliance in a patient's mouth that moves them forward or opens this up, what I've done is I've changed my rotational components, and the way the venous system drains is it requires this condyle to press on it transiently. But that's the mechanism. It's like flushing a toilet, pushing the lever. And so when I have an appliance in the mouth, I have to start asking this question. What happens to my rotation endpoints? And what happens to my anterior venous plexus and my clearance rates in the back part of this when they're wearing an appliance? Regardless of whether it's a centric relation appliance or it's, according to LVI, neuromuscular or GNM, you're still moving that condyle forward in those schools of thought, and they're talking about this as if it's a physiologic occlusion. It's not. They're chasing the disc. What they're really trying to do is get you people who are suffering comfortable. But you're making a big compromise. There's a trade going on over here. Now, it may be worth it for you to undergo that trade. This treatment is expensive, but it depends on what the cause here is. Because if the cause is a dangerous disease, then you've got a real issue. And I have made improvements in patients who do have diseases, and when I discovered what was causing it, I was really disturbed and annoyed about it. Because if you're making improvements and leaving the other part of the diagnosis on the table, you're not doing anybody a service, except giving them symptomatic relief. Now, I'm all for symptomatic relief. I don't have a problem with that. But I don't like the idea that our diagnosis is incomplete. And that's part of my mantra over here in educating my patients and the professional community. So here we have a situation where the displacement of the disc could be described by vascular hypertension. We could describe the injury to the blood vessels in terms of Virchow's triad, which I will get to in other lectures, but this creates what's called a hypercoagulability model. This is where clots come from if you wear an appliance full time. Even in patients who wear it part-time, it doesn't discount the fact that they can still get increased vascular abnormalities described by these two phenomena. And here we come to the real ending of the story. This disc is not being pulled out by muscle. It's being pushed out or squeezed out like a watermelon seed by fluid hydrostatic pressure forces, hydrodynamic forces. You've got effusions and joint fluid in here, and this is what I call a fibrotic derangement. So I will end over here in this rather lengthy lecture, as I've rocked it out enough for today with jaw talk. I hope to continue along these lines, and I hope that you've benefited from today's talk and walk away with a new perspective on what's going on over here and where disc displacement actually comes from. I thank you for your time today. Have a great day.